Ja, schönen guten Tag, liebe
Well,
Kollegen.
very good morning, dear colleagues.
Ich bin Rainer Wenning,
I'm Rainer Wenning, and I work at the Permanent Representation of North Westphalia to the EU and look after health policy together with Wolfgang Borde from Thuringia, who is the chair of the Working Group Health. It is a little difficult these days to actually address other topics. I would have never thought that in my tender age of 61, I would experience war in the middle of Europe. But we have to try to make the best of it. The topic we want to look at today and have to look at today, to my mind, is the European health data space. What kind of data is needed is very important. And this is why I am also grateful to the National Association of Statutory Health Insurance Physicians for actually contributing to this event so prominently. We will, the agenda is known to all of you. Bernd Greve will briefly speak about the standardization of health data. After a Q&A session, we have Hugo van Hastert of DG Santé with us today, speaking about the European Health Data Space. Then the Deputy Chairman of the KBV, Dr. Stefan Hofmeister, from the practitioner's view. This is from the view of doctors and psychotherapists. And then we will have a general discussion to conclude. Our facilitator will be our colleague Sten Benecke, the head of the office here in Brussels, the KBV office in Brussels. Thank you very much, Sten, because you had the hardest work to prepare this. I would also like to welcome the colleagues from the Working Party Research Science, as long as they're here, and the colleagues from the EU Conference of Health Ministers. And a very warm welcome to all of you in Germany. We should start without any further ado. I don't want to actually present a huge welcoming address because the colleagues to follow know everything a lot better than I do. I would like to remind you that we're actually transmitting this live. It will also be recorded and made available on YouTube. Whoever does not want his or her video to be featured should switch off their video cameras. You can actually use the Zoom chat function to ask questions. We will pass it on to Sten Benecke. Mr. Greve, the standardization of health data, mission impossible? How do we have to imagine this back home in Germany, but also across Europe from northern Finland to southern Portugal? Maybe you can help us with some new findings. Thank you. Rainer, allow me to briefly intervene and say a few words before Mr. Greve can kick off. A very warm welcome on behalf of the KBV, the National Association of Statutory Health Insurance Physicians. Visitors do not have a video and microphone function. So if you want to participate in the discussion and ask questions, please raise your hand using the symbol in the Zoom bar or actually send a chat message. We will then actually unmute your video and your microphone. Unless you explicitly only want to send a message, you are welcome to do this as well. And we can actually pick up on your question in the chat here at the panel.
English-speaking audience, hello and warm welcome to you. I know there are several colleagues online. Nice to have you here. And there's an interpretation, and you find this little icon on the right bottom of the Zoom monitor screen, and there you can change English or German easily. Vielleicht noch kurz eine Einführung nochmal inhaltlich.
Maybe briefly, by way of introduction, digitization is one of the big topics for the EU. It is actually pushed by the Commission and the Parliament in all the possible directions. Standards are being set for all of Europe, standards that will also have a global impact. And this also applies to the health area. We know this from the national level. We know the challenges that come with this, and now, not only now, but this process is also taking place on the European level. Recently, in the Special Committee of the EU Parliament on Artificial Intelligence, there was a hearing on the fine report, and the image was presented that the data for digitization is and looks as like petrol for works like petrol for an engine. So data is the new fuel for the digitization engine supposed to drive Europe. I want to pick up on this image now and enhance it. And Mr. Greve will probably actually not be happy with me because petrol does not come from a pump, just like this. It needs to be refined from crude oil. And maybe this is the image that should guide us today, because we do not just need any data, just any health data to make digitization successful, but we need standardized data. Standardized health data would be the true fuel for the engine, so that we can actually get on board in Hamburg, take a stopover in Paris, and end up in Madrid. Maybe I've been a little bit too daring in technical terms, Mr. Greve. Maybe you can correct me, and I would like to ask you to start with your presentation now. Thank you very much. Well, welcome. Thank you very much. No, I don't want to rant at all. This image is quite apt insofar as fuel is standardized. We have E95. This is already a European speak. Not bad at all. And data needs to be standardized just as well. Today, I want to look behind the scenes when it comes to the standardization of health data, and would like to share my screen to this end. Now you should be able to see my charts. And in full screen mode now as well. My name is Bernd Greve. I am the CEO, part of KBV, and also the CEO of MIO 42 GmbH. MIO 42 GmbH and KB4 is an important instance in Germany when it comes to the standardization of data. MIO 42, who is this? The KBV, the Federal Association, has actually spun off MIO 42 GmbH as 100% subsidiary to fulfill a government mandate. This mandate was issued to the German National Association of Statutory Health Insurance Players, and the brief was to define the semantic and syntactic interoperability for the content of the electronic patient record file. This is done by KVB through its subsidiary MIO 42. To this end, we have recruited 1/3 physicians, but also encoding experts and informatics experts. This is important to mention at this point, because the standardization of medical data cannot be done without the expertise of the parties affected, from the medical professions, from nursing care, and with a medical background. And this is why we have a multidisciplinary team put together here. All of the work and all of the results, or the standards rather, are published and made available free of charge, of course, through the website of KBV.
standardisierten Daten.
What is standardized data? Mr. Benecke already gave us this image of the fuel. We hadn't used this image yet. This was a good inspiration. We initially looked at the analogy of language, and I will try to explain this with a little video now. And I do hope that you can hear this now. The computers of doctor surgeries work with different signs and languages, all the more with different hospitals, surgeries, and pharmacies. They too need a translation support, and this again needs clear grammar rules. And this is exactly what KBV is currently developing, the semantic and syntactic interoperability of content for the electronic patient file, or in other words, one language spoken with clear grammar rules and vocabulary for all, so understandable for each and everyone, or at least that can be reliably translated.
Müssen wir eins weitergehen. So schön hätte ich das.
Well, I could have never phrased it that nicely. This is why I always use this video. The analogy is not fuel here, but it is language, human language. And this fits, I think, the EU very well. In technical terms, we try to find this single language for medical data. And why do you need this? First and foremost, we want to make IT systems interoperable. What does this mean? They are supposed to exchange data, and you could also exchange PDF files or scans, but they are to interpret this data and understand this data. So for the health sector, for a surgery administration system, hospital information systems, the cell phones of insured persons, and apps that actually show this data, then this sounds, in terms of definition, very simple. But when you look at the many different actors and players involved that communicate with each other, it becomes very clear that this is a very ambitious goal. In Germany, we have about 100,000 doctor surgeries. We have 160 manufacturers of surgery management systems. All of these systems have to be able to communicate with each other. And there are other hospitals, midwives, pharmacies, the insured persons themselves, and other service providers. And all of them are to be able to exchange data with their IT systems. This is not an easy feat. And this is exactly where we kick in, MIO24, to provide the basis for this to work, so that data can be exchanged and that this data can also be processed and interpreted. In Germany, as one way, the electronic patient record was established. It does exist already. And the medical information objects can also be stored in this patient file. The first aim is, of course, to improve care. The data is to be stored in the patient file in an interoperable fashion. Then it should be made available for care at the optimal point in time. But the legislator has also ruled that it should be visible for patients. And to this end, there are so-called insured persons front apps. This is apps that are actually provided by the sickness funds to the patients, allowing them to see the data. And this data can then also be donated to science later, where it is available for personalized medical care and for training artificial intelligence systems, for example. But to achieve all of these objectives, we have to look a little deeper and take a look at the MIOS themselves. What is this standardized data and how did this all come about? As I said, scans and PDFs are not sufficient for IT systems to really decode these data. In Germany, we had standardization efforts, the individual sectors, the established panel doctors, for instance, tried to standardize data for settlement with the National Association or with the individual sickness funds or the exchange of laboratory data. Then individual units also looked at standardization, for instance, within a hospital or a chain of hospitals, but the sectoral limits and borders were hard to overcome. And this was taken by the legislator as a reason for actually introducing a paragraph into the Social Code 5, Volume 5. And the brief was to semantically and syntactically structure this data. And to this end, we have created a very transparent process that actually involves the public, the professional associations, the IT industry, and other initiatives, or the SNOMED community. Then the medical informatics initiative is also involved, also and always with the aim to achieve maximum transparency when developing these standards. Also, in formal terms, we try to keep everything very transparent. All topics start with phase 1, such as the vaccination passport, which was initiated by lawmakers, but there are also requests made by the sectors themselves, such as image giving technologies. And these sectors actually ask for further standardization regarding the electronic patient record. We first provide an overview of this area. In image giving technologies, for instance, technical reviews are done, the organizations are involved that are of relevance here. And as soon as we've got first results, these results are being published on the website. Then public commenting is possible. Everyone can actually enter his or her comment. And we actually give a feedback for all of the comments. Then there is a legal so-called establishment of consensus. So this says which parties need to be involved and their reiteration cycles. So from 3 and 4, you go back to phase 2, where new content is developed. But at the end, the board of the KBV lays down the standards that will be valid for all of the systems that actually feed data into the electronic patient record. Well, what MIOS exist already? There's the vaccination passport. The legislator, by giving this mandate, has also actually described or actually stipulated the dentist's bonus voucher, the maternity passport, and the children's voucher booklet. Then the patient brief record from hospitals. We got the briefing to create a MIO for the discharge letter. And there were also digital aspects and the digital health applications and the telemedical monitoring. These works were started, some were already completed. The first MIOS, medical information object projects have been submitted and will be implemented by the systems. The other MIOS are still under generation, so to speak, but you can also read this on the website I stated. Let me drill a little deeper. What is this a MIO? On the left upper hand corner, you can see the source text. This is XML. This is the frame syntax in which this is laid down. And the board of the KBF is happy about this because this is laid down for programmers information. And this is just an example, but this is what needs to be laid down within the syntax. And the code systems used for the vaccination passport, for instance, there's CT, and the big advantage of the registered codes is that this can be used and transmitted across all of Europe. This can be displayed in the local language, but it can also be machine read or the like. Yes, and this already brings me to the relevance of all of this for the EU. We're speaking about the European health data space, and here on the EU level, you have to make stipulations. In Germany, we've done this. We have individual MIOS that are foreseen for cross-border exchange of information. This is the brief patient file, the patient summary that needs to be provided for cross-border information exchange by law. All of the MIOS are semantically encoded, in most cases using SNOMED CT. And this then also makes it possible to understand this information across borders and to have a display in local languages, as long as the other countries use this encoding system. And if the receiving IT system is familiar with SNOMED CT. The syntax is also specified. It is always the same for all of our MIOS. It's HL7 FHIR. We expect millions of documents to be created in this syntax. Data can even be donated. Data will also be machine readable for permissible follow-up use. And anonymization is also foreseen by law. This is easier to do. It is not easy, but it's easier to do than with PDF files or X-ray scans where you try to blacken out information. This would be possible in an automated fashion through stencils here and masking. What are the challenges? This is the introduction problem. This is to be standardized. Once we have a standardized European health data space, then it makes sense in terms of care, at least, that in the holiday country, for instance, the patient record can be read, is understood. But to this end, on the EU level, decision must be taken on a technical level, on an encoding level, for instance, but also on the level of qualified electronic signatures under these documents or on these documents. This should be as standardized as possible. In Germany, people opted for one syntax. This has benefits and drawbacks. First of all, everyone has to adopt these syntaxes, but once it works, then everybody speaks the same language. But in the EU, with different countries and systems, local systems, this will be easy. The same applies to encoding. Think of Snowbird CT, there are license costs involved. Some countries are already using Snowbird CT, others aren't yet. This shouldn't be forgotten. And one point that you should never forget, those who enter the data here are in healthcare. This is the main purpose for this documentation. Documenting is not getting any easier. IT systems can support, but there will be an additional workload, and this should not be forgotten either. When you think of the many possibilities of the subsequent use, somebody has to work in this area too. And this workload will not diminish through all of the specifications. I would like to conclude with this, providing you with a deeper insight into the standardization, what's needed for it before this data can be used. Thank you very much.
Ja, vielen Dank, Herr Greve, für
Thank you very
diesen
much, Mr. Greve, for this insight into the machine room of digitalization.
Können wir aber auch noch machen, wenn hier Bedarf besteht.
If we want to, we can now dig deeper. We now have a bit of time for some questions, for technical questions, because of course it is a rather complicated topic. And that's why I'd now like to ask the audience if you have any questions. We're here to answer your questions. Mr. Greve can do this. I won't be able to. I've learned that everyone that deals with this always says, I hardly know anything. So if the experts know little or nothing, then I do wonder how much do I know. So yes. It is always surprising how technical it is. I've seen that Wolfgang Border would like to take the floor. Just a second, please. For some reason, I can't activate his microphone. Just a second, please. It should work now. There he is. Thank you very much for this introduction. I had technical issues and joined in somewhat later, but it was very interesting. And my question is, how are we going to agree to a syntax at the EU level, which of course will be required? How high is the likelihood? And of course, this isn't a marginal issue. It is perhaps the thing that matters most for good cooperation. How high is the likelihood that we'll reach an agreement? I would imagine that there are different financial and economic interests by the people installing something. So there's certainly going to be a competition too. Could you perhaps say more about that? Could you perhaps give us a brief estimate as to how this is going to pan out at an EU level? I'm no lobbying expert at an EU level with regard to the countries and industries, but I do know that the EU itself has already made different proposals all the way down to the syntax. The clinical document architecture CDA is usually proposed here. It's a precursor of HL7 Fire. So as far as I can see, one is willing to do this, but these aren't binding rules as soon as it comes to binding matters. There will be difficulties, I said this in my slides, because those that do not use the syntax yet will have to do something novel. They'll have to change the programming language, and they will also have to replace running systems that are already running now, and only because they will have to use another syntax. So here some convincing work might need to be done, but this will be required if we want to create such a health data space. Then such decisions will have to be taken. Normally, this can be somewhat mitigated via transition periods. But during that time, of course, there won't be 100% syntax compatibility. One could say during the first 5 years, we'll only use a few standards. At first, this will ensure that people come on board, but this is where my knowledge of the EU processes also stops. Thank you very much. I could see that Dr. Hofmeister wanted to take the floor. Thank you very much. I found your question very interesting, and I certainly do not have any technical knowledge because I'm a doctor, but I could say more about how the discussions were held in Germany. As a doctor, I know that many centers around the world are dealing with standardization because, of course, this makes our work a lot easier. But when I say many centers and when I say standardization, this already in itself depicts the problem.
Physikalisch ganz banale Ableitung von Spannung gegen Zeit. Also eigentlich was wirklich zweidimensional ist.
So of course we have different dimensions that come into play here, but for many reasons, for economic reasons as well, one ensures that, for example, different formats cannot be read by different providers. But of course, that would be the goal, that we are able to understand two different formats that are provided by different economic operators, thus ensuring that every doctor in the world will be able to obtain data and formats that he or she can use. So we have economic dimensions here, we have scientific dimensions that come into play. And when you standardize, of course, there can only be one, and that's the big challenge. And Mr. Krever used the example of the vaccination passport. And when you think of Corona, it is obvious how ideal it would have been if within the EU, we would have had one vaccine passport that works seamlessly across borders digitally and is readable by all institutions and persons. I think this would have avoided a lot of extra work in the different countries. So of course, there is huge potential for these things, but again, it is tied to great challenges. I'll say more about that later. And the challenges are going to be who standardizes, and then of course everyone will have to adhere to that. We also thought about transcriptions and translations, but this isn't working well enough yet. Whether AI is going to help out here is something I'm not entirely sure yet too. Thank you very much for this question and answer. I could see there's a question in the chat. Somebody's asking how high the costs are going to be for the process that MIOS 42 is currently implementing. Who would like to answer this question? Perhaps I can say something about this. The costs for MIOS 42 are going to be refinanced, also directly according to law, and that via the so-called gematik. We currently have 22 employees. They're responsible for most of the costs that we have, and they are entirely refinanced. There are no project means, such as for research projects for X amount of years. Instead, we have a permanent mandate to bring about standardization in Germany. And this is nothing that is going to finish after 3 or 5 or 10 years. Perhaps you might think, well, at some point everything will be standardized, but I do not believe in this. And Mr. Hofmeister already said how many people around the world are working on this ongoing process. And of course, the medical sector is developing, standardization is also continuing to develop when it comes to those things that we have standardized, such as the children examination booklets. Here, with regards to the templates, new things are being decided. And then, of course, the digital information objects will also have to be continuously developed, which is why this is a task that will run permanently and not end at a specific point in time. Ms. Völpe raised her hand. Now I can't see it anymore. Would you like to take the floor? Mrs. Völpe, you have the floor.
Ja, ich habe eine Frage nochmal
Thank you very
vor dem
much.
Hintergrund, dass
I
wir
have
ja
one
schon seit
question
mindestens 10 Jahren
against the
über
background
E-Health sprechen
that we
und
have been
über die
speaking for 10 years
weil wir
about
ja die Patientenrechte
e-health
Richtlinie hatten. Und das war ja
and
quasi der
the
Beginn der
Patient
Patientenakte,
Rights
darüber zu sprechen,
Directive,
über
and that was kind
E-Prescription.
of the
Bin
start
ja doch
of
jetzt ein
speaking
bisschen
about
erstaunt
so-called
darüber,
e-prescriptions.
dass wir bei
I'm somewhat
der
surprised about the following.
Standardisierung, also bezogen auf die
When it
Syntax
comes to
quasi so
standardizing,
von
when it
vorne
comes to the
anfangen müssen.
syntax,
Also ich
I'm
bin immer
surprised that
davon
we have to
ausgegangen,
start
dass diese
at the very
Patientenakte
beginning.
wird ja schon zwischen
I always
Mitgliedstaaten in der
assumed
Tat aktiv
that the health
ausgetauscht.
record is already
Deutschland
being
gehörte dazu
exchanged
nicht,
between
aber
member
zwischen anderen
states.
Staaten, sodass ich
Germany was not
denke,
part of it, but
immer
other
gedacht
member
habe, dass
states
man da
were,
einen
which
Standard
is why I
hat,
always thought
austauschen
that
zu
we
können,
have a
Informationen.
standard to be
Und
able to
jetzt durch die
exchange
Einlassung von Herrn Greve
information.
oder
And now,
Darstellung,
Mr.
habe ich
Greve's
das Gefühl,
presentation
wir
has
fangen jetzt
suggested
quasi bei den
that we're
Gesundheitsdatenraum
basically
von vorne an,
starting at the very
uns auf einen
beginning
gemeinsamen Standard zu verständigen. Ist
by
dem so? Oder können
deciding
wir
what
doch im
standard
Grunde
to
genommen, gibt es doch
use
schon eine
to
Mehrheit von
communicate. Is that the
Mitgliedstaaten,
case?
die sich
Or
auf
isn't
einen
there already a
Standard
majority of member
verständigt hat?
states that have agreed to a standard?
Ja, danke, Frau Völpe. Und erstmal Entschuldigung, ich hätte Sie auch per Bild freischalten können. Ich habe
Apologies, I should have turned on your
Macht
camera.
nichts.
I wasn't aware of the fact that I could do that. Everyone following you will be able to be seen too. Now, I think that Mr. Hastad from the European Commission is going to be able to answer this question, but perhaps before that, Mr. Greve. Certainly not as well, but I'll try. According to my knowledge, most countries in the EU use different standards. They can, of course, exchange data via PDF. They can also exchange Word documents. So it's not like it doesn't work or isn't possible, but these documents aren't readable by machines. They aren't indexed. Let's imagine the following. My health record has been established for many, many years. Then if I am in emergency care, it would be important for not all of this to have to be read in order to find the pressing issues. One needs to be able to find information quickly. There are countries in the EU that already have structured documents with a corresponding syntax. Austria, for example, has already used HL7 as far as I know, but HL7 CTA, not FIRE. So I don't want to be too negative, but I do believe that it is somewhat right that one would have to meddle with that point in the syntax. One could say that for the EU, the data space starts with PDFs, and the entry barrier would be very low, but the usage would also be very limited. These are decisions that Germany has taken for itself, but will still need to be taken at an EU level. Thank you very much, Mr. Greve. Perhaps a comment from me. There are the joint actions where a lot of member states are already working on such questions. And perhaps Mr. Van Haastad could tell us more about this later on too. Because there is work being done for a common understanding already. There's another question in the chat. There's a question whether the MIOS are going to be combined when conducting different visits. Mr. Greve, I'm not sure if I entirely understand the question, says the speaker, but at least it could be said that all data that is collected for one specific patient will, of course, then be added to, for example, my health record. And the author is mentioned in the documents, both for the metadata, but also within the documents themselves. So the data is available, but how this is going to be used via ties or feedback loops, that is no longer our task. That is the work of the Gematics that are responsible for the health records. I don't think this is currently happening via machines.
Dann sehe ich noch eine Frage, die
I could see there's another question, whether the medical technology industry is involved in the process of establishing MIOS. Well, we're diving quite deeply now. We're talking about the DIGA device toolkit here. Perhaps not everyone knows this. These are the digital health applications. According to the lawmaker, these apps are also to be able to feed data into the electronic health records. And these apps are also to be able to read data from sensors such as fitness watches and the like. All of this can be purchased for individuals. So this data is also to be read and then fed into the records. For the industry, for medical technology, this is extremely relevant. In Germany, we have associations that were very much involved in the lawmaking process, and they can also partake in our processes. I have also already had contacts. All our work is public with commenting procedures. So everyone, every interested party can partake directly. Together with B-Farm, we are also directly speaking to manufacturers. We have different discussion rounds that allow for exchanges. There's another question relating to the EU level. And you can rest assured we'll ask this question directly to Mr. Van Haastert. Mrs. Völpel's hand is still raised. Oh, I could see that it's been taken down. Does anyone else have any more question? That doesn't seem to be the case. Well, at the end of our event, we'll have another discussion, which will be another opportunity for the audience to ask their questions. The new health commissioner, Mr. Kyriakides, took up her mandate. She received a so-called mission letter from Ursula von der Leyen, and in it, it was clearly stated that it should be her task to create a European health data space. And that is why we're here today, because this is more than 2 years ago now. A lot of discussions were had about it. The public was involved in consultations, the parliament, of course, too. And now in April, it looks like we'll have the first legal initiative on this matter. So we'll have the normal lawmaking process via the Parliament and Council, which will commence. And of course, we're going to be pursuing this in Brussels. This is certainly going to be a very important agenda item that we're certainly going to have to deal with intensively. We're very happy that we have a guest from the Commission amongst us, Hugo van Hastert. I have to admit that I've seen him quite regularly of late, because he's been answering a lot of questions about the European health data space. He's been kind enough to respond to questions again and again. That is also going to be the case today. Thank you very much for joining us. We've been in touch ahead of this event, and we discussed what would be the best thing that you could inform us about today, because of course, the European health data space is a huge topic for which a few minutes won't be enough. But yeah, perhaps I'll give you the floor now, and then we'll see whether we have any further questions that we can discuss together with you. Mr. van Hastert, can you hear me? If yes, I kindly ask you to give us your statement.
Thank you so much for this opportunity to present the European health data space proposal, as we've been preparing it on the side of DG Santé in the European Commission. I'll just show you some slides to take you through the proposal itself. So let's see if you can see my screen. You should be able to see the presentation right now. So indeed, as I only have a limited amount of time, let me just briefly introduce the proposal, and then I'll be happy to take your questions and have a discussion. So the European Health Data Space, a legal proposal that will be launching in April, looks at the primary and the secondary use of health data. So we've already in this meeting heard a lot about the primary use of health data, the use of health data in the clinical setting, with doctors and nurses collecting and using health data for treatment and for diagnosis, etc. There's also the secondary use of health data, which the proposal will also address, which is the reusing of health data. So this is where you reuse health data for research, innovation, policy making, regulatory purposes, and other purposes. But I'll focus for now on the primary use of health data, as this is the main focus of your meeting. So what we've done the last couple of months and years is identify the problems and the challenges in this space. And what we see is that patients have limited control over their health data, and there is limited interoperability between healthcare providers. It's very difficult indeed to access health data across different IT solutions, across different points of care. And this is where we'd like to improve this with the EHDS proposal, to promote the control of patients over the data, to promote interoperability, to strengthen the role of e-health agencies when it comes to cross-border exchange, and to reinforce existing governance and the existing infrastructure. And also, we see that there are a number of problems when it comes to the single market, because of fragmentation at the national level, at the regional level, at the local level, we see a lot of fragmentation. And this is creating barriers, and these barriers make it very difficult indeed to use the different services across borders, to scale these up, to exchange data. And this is why we're looking at labeling or certification to promote the interoperability. Obviously, the EHDS proposal doesn't stand alone. It's very much connected to existing and recently put forward pieces of legislation. So we have the Cross-Border Healthcare Directive from 2011. We have, of course, GDPR in place. We have the proposal for the DGA and for the Data Act, which has recently been published by the Commission, just like the AI Act. Of course, we have the existing medical devices regulation, and we also have EIDAS, which pertains to the identification of both patients and also healthcare professionals. So all these pieces of legislation are relevant. And then if you look at a very simplified overview of what we're trying to address with the EHDS is to make sure that individuals have better access to their health data, that healthcare professionals have better access to health data where it is relevant to them, that providers of digital health services and products no longer face as many barriers as they do today. And then at the bottom of the screen, you also see the use cases for secondary use of health data. And the objective is to empower citizens to control their data, to foster a single market for digital health services and products, to ensure interoperability and security of health data, and to create a level playing field for manufacturers. Really this ties into the current state of large fragmentation across the EU, but also the fact that in many member states, health data is not yet always available in a digital format. Often it's still available in a paper format. When it is stored digitally, it's not necessarily done in a certain standard, which makes it very difficult to exchange indeed. So these are things we're addressing. Also, when it comes to the tools that people have at their disposal right now to access health data, these are also fragmented. In many member states, we see national portals. Sometimes people have regional or local portals at their disposal as a patient or as a healthcare professional. Of course, in Germany, there is the solution of the app through the health insurers. The Netherlands is developing another system which will have different apps, which will be able to access health data from different points of care on the basis of certain standards. But really, the majority of member states have already introduced national portals where people can access their health records digitally. And this fragmentation across the EU is something that we'd like to address. So we have the existing infrastructure, MyHealth@EU. This is already live now in 10 member states, including Spain, Portugal, France, the Netherlands, the Czech Republic, Finland, Estonia, and many more countries will be joining in the months and years ahead. And we also just recently closed a call for funding for the remaining 6 countries that don't have plans yet to set up a national contact point for e-health, which includes Germany, but also Denmark and Austria. And we are happy to report indeed that all these countries, including the countries outside the EU, but in the EEA, such as Norway and Iceland, intend to set up a national contact point. And the relevance here is, of course, that the system currently exchanges 2 sets of health data. It's the patient summaries and the e-prescription, but these sets will actually be expanded. So we have the project already underway, which is called
The recording has stopped.
So the project Cross eHealth is actually developing further health data categories. These are medical images, lab results, discharge reports, and we're exploring further expansions. For instance, the vaccination card, as it's called, so that also the health data in the area of vaccines could be exchanged through MyHealth@EU. And this is being developed also with the involvement from Germany. For instance, people from Gematik in Germany are also involved in these discussions. So the proposal will look at expanding the rights of citizens to access and portability of their data, strengthening the existing governance and, of course, the infrastructure that I just mentioned, and also promoting interoperability of health software solutions, which again resonates very strongly with what I've just heard, and we've already learned in many discussions with the German colleagues that the national efforts in Germany are very well indeed connected to the efforts that we have identified at the EU level. We also have a number of studies that have been completed or will be completed soon to feed into the proposal. We've had a public consultation, the results of which have been published and are online. There has been a study on the assessment of rules in member states on health data, a study on the interoperability of digital health systems, and a study on the use of real-world data. Before we publish the proposal itself in April, we'll also be sharing studies on regulatory gaps, an infrastructure study, and an impact assessment. So those will be interesting to look forward to in April as well. And then when it comes to things that we're doing already to advance the digital health and health data space, We have a pilot project that will be launched to grant patients access to the health data that's now available in My Healthy to You. As I said, we are expanding My Healthy to You to the all 27 member states and the 2 EEA countries. So 29 countries in total will be connected at some point. And we'll also be running a pilot for the secondary use of health data. And through the RRF, the Recovery and Resilience Fund, member states have put forward 12 billion euros of funding proposals for digital health. So thank you for the opportunity to present EHDS in a very brief and succinct manner. We look forward, of course, to your response once it's published in April. And please feel free to reach out to us if you have any further questions.
Herzlichen Dank, Hugo van Hastert.
Thank you very much, Hugo van Hastert, for this overview. And I think quite a lot has been said that is also tied to what's been said at the beginning. And I can see that some questions have come about. Now, perhaps we'll start with the following. Interoperability of health data is part of the work package. How far have you come in this space?
So indeed, the interoperability and really the standardization efforts are already well underway. So as indicated, we have guidelines that have been developed through the collaboration in the eHealth network in the space of the patient summaries and e-prescription. And the project across eHealth is due to end its activities in August, September. But already we have deliverables coming from them in, for instance, medical images and lab results. So we'll be translating those deliverables from the project into new guidelines for the eHealth network, for My Healthy to You, which basically means that member states will be able to implement these standards at the national level. And then if you have the current situation that Finland is connected and France is connected, and the medical images guidelines are implemented both in France and in Finland, and they've gone through all the checks and the audits, then a doctor from Finland who has performed, has collected medical images, and these are available in the Finnish digital health systems. But then the patient travels to France for whatever reason, then the French doctors, through My Healthy to You, will be able to consult these medical images in the French digital health systems. This, of course, requires a lot of technical implementation, standardization. It requires also privacy concerns to be addressed, security concerns, etc., which is all done through the My Healthy to You project. But this is where we stand right now. We have the 2 sets of health data categories standardized and available for guidelines, and this is soon to be expanded.
Vielen Dank erstmal dafür.
Thank you very much for this statement. Now I would like to know from our audience, any clarification questions? Because when we delve a little deeper, it's going to get more political, and it will be hard to actually separate one from the other. And this is why I would suggest to now actually listen to the statement by Dr. Hofmeister, so that we get the practical perspectives of doctors and psychotherapists for our debate. I've already seen many questions, and then we can actually kick off our discussion. Did you want to ask a question? Yes, I withdrew because I look forward to the political discussion. I have one question for Mr. van Hastert. I suppose that this proposal in April will actually be based on the internal market article. Is this correct?
Indeed, this is a correct assumption. The proposal aims to further strengthen the internal market, and therefore you can expect the legal base to depend importantly on this aspect of the treaties of the EU.
Ja, vielen Dank. Das ist ja schon
Well, thank you very much. This was a very important point. So we already know, I mean, those working in Brussels, where we're headed. But we're not that far yet. We will first listen to the KBV, and I would like to pass the floor to Dr. Steinhofmeister. Well,
Enlightening. Sehr geehrte Damen und Herren, ich komme nicht umhin.
Ladies and gentlemen, I have to briefly say something about the German National Association of Statutory Health Insurance Physicians, because it is a very special institution not known to everyone, and maybe it will become clearer why we are tackling this topic here today. The KBV organize outpatient physicians and psychotherapeutic care for about 99% of the population in Germany. We do this within the framework of the statutory health insurance and in accordance with the legal mandate. Our work is defined in the Social Code Book 5 as medical self-administration, which means that we belong to the indirect state administration. The KBV is therefore neither a lobbying association nor a trade union. We're the indirect state administration. The KBV at the federal level and the 17 regional associations of panel doctors ensure, in North Rhine-Westphalia we have 2, in all other states we have 1, they ensure that more than 180,000 doctors and psychotherapists are able to care for their patients. And they have about 1 billion doctor-patient contacts per year. This means there's a close connection between everyday practice and the organization of healthcare resulting from the statutory tasks. So today I am speaking for these doctors and psychotherapists who work in the outpatient sector. It is their practices where the vast majority of health data is collected. But we do not only collect a lot of health data in our daily work, but we also store a lot of special data, and we also transmit a lot of health data routinely within the health system, and for a long, long time already. Mr. Greve already presented to you that the KBV has also been tasked for some years with standardizing health data in Germany for the entire system across sectors and professions. We are therefore looking with particular interest at the EDHS, the European Health Data Space, and what will be associated with it. However, I would like to leave the technical level and turn to an essential underlying question, namely the question of whether and why we should tackle the digitization of healthcare at the European level. It is the question of what we want to achieve. What do we want? How do we want to achieve this? Is it realistic that we will achieve our goals? Since I'm responsible for healthcare in Germany, I also ask, what are the consequences for healthcare in our country? From this perspective, I would like to put forward 3 thoughts for discussion below. My first thought: in Germany, the principle of data economy applies. By law, we in Germany are not allowed to collect any data, and certainly not to pass on any data, if the purpose is not precisely defined. We're not allowed to collect data simply in order to be able to keep large amounts of data. So whenever we want to make available data for research purposes, we have to submit this to our ministries and get permission in each individual case. And for this restricted area, the data sets can be handed over to science. This principle also applies to other public areas, not only the healthcare service. We've just heard about the great goals that are to be realized with the EHDS in Germany. For many years, we've had a digitization debate that was driven by apparent feasibility. In the process, we always lost sight of the goal we pursue with digitization. This has led to considerable acceptance problems in some cases, both with with patients, both with citizens and the doctors and the psychotherapists who capture the data. I think we should not make the same mistake in Europe and have a better start to digitization. We need to have a debate about which concrete care processes are to be improved with the data. Abstract, perhaps even cloudy descriptions of what digitization should bring in concrete terms do not help us. We need a debate on why data should be released. It starts with a patient who wants to know what he will receive in return for his data. And it continues with us doctors who have to be sure that the confidential doctor-patient relationship is not undermined. At the moment, I am missing the necessary substance in the debate and hope that this will come in the course of the discussions. So less what's feasible, but what makes sense and what is necessary. The group meetings of the EU Parliament have been scheduled for today, so we cannot have an MEP with us. I would love to ask a German MEP how this is envisioned in the EHDS as a co-legislator of Europe. My second thought, Germany's healthcare is organized according to the principle of subsidiarity, and so is the entire EU. It is not without reason that health and social policy are reserved to the member states. Intuitively, everyone can probably agree when there is a talk of a Europe of equal healthcare for all. But what reads well on paper comes up against its own regional challenges in practice, and there cannot be any central answers to this. We've had very good experiences with organizing care at the regional level and with individual responsibility. This was clearly seen in the COVID-19 pandemic. An EHDS will inevitably bring about data standardization. We must work to ensure that it enables local solutions and does not lead to uniformity in healthcare. So finding the chances and clearly defining risks. Another word on standardization. We've just heard how many actors in Germany are involved in this process. And this is only about the health system of a single country. But how is this supposed to work on the European level? Who makes these revolutionary decisions? How is it politically ensured that technology and standards do not determine the care process instead of the other way around? How is it to be ensured that standards make their contribution to achieving these care goals? All of this should be discussed publicly, and this should not be left to technical experts. If we do not do this, the consequences and acceptance would be considerable. My third thought, the EU Commission recently presented its draft for Europe's fundamental digital rights. This is a big step, and I can only welcome it. The commonplace that can be heard everywhere is very apt here. Data is the oil, is the fuel of the new age. This is accompanied by a tremendous economic dynamic. We have to be careful that people are not overwhelmed by it. I therefore think it is absolutely right the EU defines fundamental rights here. Neither consumers nor companies, and certainly not patients, should be at the mercy of the pure logic of a data economy. Scenarios that we already see in China today. No one in Europe wants to see that. It is therefore right that the EU Commission does not place technology in the foreground with the digital fundamental rights. In other words, it does not elevate what is technically possible to the maximum. Instead, it puts people at the center. As a doctor, I would like to add, let us see the patient and the human being at the same time. Patient sovereignty is an essential value that the EU takes into consideration in its legislation. I don't want to open Pandora's box and talk about the absolutely necessary protection of this data. Here, the public is rightly critical and very attentive. Rather, I would like to pick out another essential detail. Patients should decide for themselves how their data is to be handled and to whom it is made available. That is how it is planned in Germany with the electronic patient record, and what is probably how it will be in a later European version. As a doctor, however, I can never rely on the completeness of the data a patient allows me to see. Thus, higher efficiency in care is not given at all. What I'm trying to say, the art of diagnosis and the patient history, and whether we've really collected everything that is needed for treatment, This should not raise the wrong expectation that digital patient data can allow immediate treatment right away. There's really an important point. Many patients are very cautious about having their health data stored electronically, centrally. And if I read the news from France correctly, patient support for a central electronic health record was very low. So low, in fact, that the project had to be restarted. We have to learn from this for the future. And one lesson learned is that people do not choose offers if it is not clear what concrete advantages these digital tools have for their care. No cloudy advantages, but concrete advantages. And here we need much more substance and clear ideas for care, both here in Germany and at the European level, so that the citizens can support this. If we could manage doing this, we could make a big step forward. If not, this will not only not lead us anywhere, but we would even further damage trust in the benefits of digitization. We must all avoid that. To conclude, it seems to me that everyone in Brussels has long since agreed on the EHDS. In the process, I hear about all the debates about what is possible, how all this can be achieved, what technical foundations have to be created. So let me repeat what I said at the beginning. We do not talk enough about why, whether we want it. That's the decisive question. What would be the consequences for whom? Only when we have clear answers to these questions should we turn to the how of implementation. This requires a constructive and open dialogue. There's no other way. We've seen that not why, since a process is digitizable, we have to rethink processes from afresh. And one is very accessible for digitization, other things aren't. And other processes change so dramatically through digitization, which is also reflected in care then. My last sentence, please do not understand my statement as putting on the brakes. Rather, I would like to make a passionate plea for us to enter into dialogue with each other, those who develop digital applications, those who understand something about patient care and their needs. Only in this way will we gain technical solutions that really benefit, because what counts to us is patient care in Europe, and digitization is to help us in this. And on this note, we also as KBV support the European project and actually make a major constructive contribution with MIO 42 towards this standardization. So I look forward to the discussion. Thank you very much for listening. Well, thank you very much, Dr. Hofmeister. So this was the perspective, the practical perspective of doctors and psychotherapists. And it was also a plea to stop and ponder. Maybe we can actually put this into practice here too in our discussion. But I would also like to use the opportunity and to actually pick up on the last sentence you use, an open, constructive dialogue, talking to each other. And I would like to bring in Hugo van Haastad again, because this is your job at the Commission to actually obtain the coordination for such major projects. How do you experience the coordination with member states in this field and with the actors involved? Is it a technical circle in the behind closed doors in chambers, so to speak, where the decisions are taken, or would you say there is a big public debate about this, or whatever? We'd like to know from you.
Thanks so much for that question, and thanks Sir Hofmeister for stating the position of the KBV. It's I think it's a very a good position to have. It clearly indicates that you are you have the priorities of your membership very central on top of mind, which is actually what we aim to achieve in the European Commission as well. Obviously, the proposal should benefit healthcare professionals. It should benefit patients. when it comes to the the goals that we wish to achieve, it should be the further improvement of healthcare and the continuity of care, because this is actually right now a real challenge for patients whenever they move from one member state to the other, be it for travel or for work or for whatever reasons. Right now, the continuity of care is a jeopardy. And this is negatively impacting the health of EU citizens. So this is a concern for the citizens, but also if you look at the healthcare professionals, because healthcare professionals in the conversations that we've had often indicates that they need to perform their tasks. They need the right information at the right time, in the right form, for them to be able to perform their job as a doctor and a nurse. And right now, both at the national level or often at the regional level and at the European level, this is a huge challenge for healthcare professionals, and they often see that they have to call people, they have to wait for faxes to come in, they have to type information from one system to the other. It's very time-consuming. And apart from the time-consuming factor, that they feel frustrated because they want to do what they were trained to do, which is provide care, and not be involved in collecting information or doing administrative tasks, which is the cause of all the fragmentation that we have at the EU level, at the member state level, often also at the regional level. Indeed, for us, the aim is to serve the healthcare professionals, to serve the citizens in their needs. This is also why we involve a lot of stakeholders in the work that we do. We have also in the Cross eHealth project that I mentioned, we have a lot of involvement from the different member states of healthcare professionals, doctors and nurses in different countries that are involved in making sure that whatever is developed in the end will also be usable, user-friendly, and will create actual value and won't just be a paper tiger, as it were. So really for us, that having these conversations to make sure that we're doing the right things is paramount.
Dankeschön für diese
Thank
Einlassung.
you for this comment. I now see a hand. Now I can see a hand. I thought I didn't see anybody. And I will unmute Mrs. Mauers and activate her camera. You have the floor, Mrs. Mauers. It's not working, I think. Is your hand still up? No, obviously not. Well then, either Mrs. Mauers will come back, or I will actually pick a question from the chat. Again, directed to you, Mr. van Haastert, because you said that we're starting to have individual health data exchange across national borders. You mentioned health at EU, and somebody is asking how you can ensure that the patient data is properly protected when it travels across national borders.
So indeed, the data protection is an important aspect of the work that we do. We of course have the GDPR, but at the same time we're well aware of the fact that there are different interpretations of the GDPR across the EU and across member states. And of course there is a lot of national and regional legislation in place which governs the use, the collecting, the sharing of health data. So what we have done is we have introduced the MyHealth@EU infrastructure, and Germany has expressed also in Parliament its intent to join this network by creating a national contact point. So in the future, you will have in Germany also a national contact point, and then healthcare professionals will be connected to this national contact point. So if a patient from France is traveling to Köln, and they fall ill, then the German doctors at the hospital in Köln will be able to access the French health records. But this will be introduced in such a way that it complies with German legislation and EU legislation, and if necessary, regional North Rhine-Westphalia legislation and rules. This is all up to the German government when they implement this national contact point. And we see that in different member states, they all have their own distinct approaches, which is only logical because member states are quite different. But they are responsible for connecting hospitals, other points of care, GPs, pharmacies, to the national contact point, to the infrastructure, and to ensure data protection and security.
Vielen Dank.
Thank you very much. Wolfgang Borde. Yes. I don't want to dominate the discussion. No, they're not. There are no other hands raised. Well, I would like to actually ask the same question to Mr. van Hasselt regarding standardization. You also said there are too many different systems, and to allow them to communicate uniformly. Can the proposal to be expected in April do away with this? That's the first question. And the other question, and this is why I asked about the legal basis for this before. You only have limited competencies in terms of health, and of course have to base your proposal on the single market article. But isn't this in contradiction to what Dr. Hofmeister said? Technologies or technical things should not be in the foreground, but what you can reach in legal terms is only a technical standardization. So the medical value added for patients is almost like a positive, pleasant side effect.
So thanks so much for this question. So to come to the first question, which regards the many, the multitude of national, regional, local solutions that are in place. So the EU proposal would not in any way replace these. Really, it would ensure that there is interoperability between these. So you will still have in Finland a national portal for the patient to access the data. You will still have in Spain the 17 autonomous regions with their own portals and solutions in place. But what the EHDS aims to achieve, also through the infrastructure My Healthy to You, is that regardless of whether you are in Andalusia in Spain or in Finland, you will be able to access and to give access to the health data according to these European rules. And because there is interoperability and there are standards in place, this will technically be possible. Of course, at the same time, this will still be the patient deciding who has access to which data. So really, we're not replacing systems, but we're making it possible that these different systems can communicate and can exchange and talk to one another. And then to the second question, which is pertaining to the subsidiarity. So indeed, if you look at the different treaties on the EU from Lisbon to Maastricht, then you will find that the competences of the EU are very strong in some areas, such as the internal market, and not so strong when it comes to, for instance, education or healthcare. At the same time, the EHDS proposal is one in the area of digital health, and the digital domain is also a strong competence of the Commission, because what we see is that digital developments don't stop at borders and are actually an opportunity to innovate our economies and our societies, and that these require a European response. At the same time, we are fully aware of the fact that the Cross-Border Healthcare Directive gives powers to the EU Commission in the area of digital health on a voluntary basis. This is Article 14 of the Cross-Border Healthcare Directive. But we also have seen with the introduction of the EU Digital COVID Certificate that in in a situation of crisis, that the member states came together and adopted EU legislation, introducing the EU DCC and creating a legal base, making it possible that we standardize and exchange vaccine or other health data across the EU. And this introduced EU-wide legislation, which is not voluntary for the entire EU. So we do see a shift in the thinking amongst the different member states, fully aware of the fact that this is due to the COVID pandemic, and we do hope that this will at some point subside. But when it comes to the digital health challenges, this will be the big debate. Will we fall back on subsidiarity, which means that all these barriers will remain, and that patients will not be able to easily enjoy continuity of care across borders? Or do we think that there is room to interpret the treaties in such a way that we should be moving forward on this topic?
Ja, da sind wir mittendrin im Herz dieser Diskussion.
We're at the heart of this discussion now, with many different answers to it. And great that you actually announced it or explained it so clearly. This is a change of paradigm. Although digitalization is the point of departure for European regulation, it has tremendous impact on the health areas. Dr. Hofmeister raised his hand. Yes, well, thank you very much. There's one question by Mrs. Knoop for Mr. Greve, but maybe I can answer it. An example is the e-prescription. This is the digitization of a trivial process, you might think. But in the implemented technical stage today, the process that manual takes 4 seconds in analog form takes up to 60 seconds now, especially when the system breaks down in between. And this process takes place about 500 million times in surgeries. You can imagine if a process takes 10 to 15 times longer than before, and this takes place 500 million times, that this is a process that nobody would tolerate. This does not mean that e-prescriptions aren't possible. It's a smart solution, but they have to work properly and not slow down a process. And this also applies to the EDCC. We would have to agree that internal or panel doctors actually encode ECDs, because otherwise the data is useless. So lots of work and a big challenge. Thank you very much, Master van Haastad. I think you described very well that there's tremendous potential. Let me give you 2 examples of how we would like to think. If I, as a traveler, go over to Strasbourg and suffer a traffic accident there, colleagues need data for emergency treatment. So this is a completely different data set from a retired person deciding to move to Spain. I had cancer, was chronically ill, was treated, and I need the whole file. Where for the doctors to treat me as a chronically ill patient in Spain. I think we can differentiate pretty well whether we need this digital COVID certificate or the vaccination passport or certificate that actually covers a short trip, which can be read abroad and shows, well, I take diabetes, or as I change country as an EU citizen and actually have to take along all of my medical data. I think this differentiation is easy, and we don't have to be over ambitious to do everything to kill all birds with one stone. And what I've understood is that you said that you want to produce use cases first. And this is what we can endorse, I think, easily. And as doctors and as medical professionals, we see this as a big potential. Now I will try to bring back Mrs. Mauersberg, both with the microphone and a video. Mrs. Mauersberg, are you there? Can you hear us? Can you speak? It does not work. Then I have to. No, she unmuted her microphone. You should be able to hear her now, says Mr. Border. But I think this is up to your technology now, because I've really unmuted you. Now I would like to continue with Mrs. Vopel. No? And yeah, there she is. Can we see you? No. Oh, there is a question. May I remind you of the question I asked earlier? Mrs. Roda, there's a question by Mrs. Roda. No, I have no more questions. No more questions. Okay. You can see we're not really so familiar with this technology. And I would like to hand the floor to you now. It's about My Health at EU again. And the question is whether the data captured here will also be used for secondary use. Have you ever thought about this? Mr. van Haastad, question for you.
So the data that is collected and then made available through the European infrastructure My Health at EU, that is intended for the primary use of health data. At the same time, of course, we are fully aware of the fact that these health records often come from national registries, which are also available potentially for other purposes, for research purposes, for innovation, for statistics. But at the same time, that would not be the purpose of the My Health at EU infrastructure. For the reuse of health data, we would have a separate infrastructure, which would be very similar to what some member states have developed, such as Finland, Denmark, and France. They have national infrastructures in place and national institutions and national legislation governing the reuse of health data. And this would be organized separately from My Health at EU.
Darf ich an der Stelle noch einmal nachfragen? Es würde mich sehr interessieren.
May I ask, Mr. van Haastad, what is the technology of My Health at EU? Is it an online application, or how can we imagine this?
So the My Health at EU infrastructure actually builds on software which is called OpenNCP, the Open National Contact Point. So this is the European software, which is open source. This means that it is not licensed from any major IT firm, but rather it's developed by the Commission in-house together with the open source community, with experts. This ensures transparency of the software development, and it ensures that we are not dependent on industry. And at the same time, this is only the European part of the infrastructure, because really, of course, what we're doing is we are connecting national infrastructures. So we have Testa, and Testa is an existing IT infrastructure across the EU, which is used by public authorities. It is separated from the internet and highly secure. So this is used for the exchange of data. And then, of course, Testa and the OpenNCP connect to the national contact points. And this is where the member states have their own sets of software solutions in place, some of which are provided by industry, others are also developed by the governments themselves. But this is really a choice for member states to make for themselves.
Vielen Dank. Und jetzt sehe ich Frau
Thank
Maus.
you very much. Mrs. Mauer,
Das wäre toll.
you have the floor.
Ja, ich wollte auch gerne nochmal auf diesen technikfokussierten
wanted
Diskurs kommen, weil ich glaube, das
talk
ist
das
das allerwichtigste
technology
Thema,
too.
weil wir jetzt gegenwärtig ganz viele Leute aus der Diskussion um Ziele und Inhalte der Digitalisierung ausschließen, die sich da bei dem technischen Diskurs nicht firm fühlen, mitzureden. Und das drückt sich auch immer ganz klar darin aus, dass ja in Deutschland mal ganz schnell die Spezifikation fertiggestellt wird und die Partizipation im Grunde dann nachträglich erfolgt. Und zwar am Frontend. Das halte ich für ganz, ganz ungut. Und diese Definition von Use Cases muss natürlich auch von den Patientenorganisationen aus ihrem Bereich heraus erfolgen. Also jeder, der da teilnehmen soll am Netz, soll und muss die Möglichkeit haben, solche Use Cases einzubringen, damit dann in der Spezifikation einer solchen zukunftsoffenen Lösung vorgesehen werden kann. Das muss natürlich nicht bedeuten, dass sich dann jeder immer gleich mit seinen Zielen vollständig durchsetzt, aber dass das zumindest thematisiert und diskutiert wird. Also ich finde das sehr gut, was Sie, Herr Hofmeister, gesagt haben. Das muss wirklich, denke ich, jetzt aber operationalisiert werden. Also man muss jetzt eine klare Vorstellung bekommen, wann diese Partizipation erfolgt. Ich habe jetzt ein bisschen da teilnehmen können beim E-Rezept und bei der EPA, und da ging es immer nur darum, dass wir uns einen Demonstrator des Frontends angucken können. Das ist absolut unzureichend. Ja, und das ist wieder so richtig deutsch. Ja, und es ist auch wirklich so bei der gesamten Patientenbeteiligung in Deutschland, dass eigentlich Patienten immer da beteiligt werden, wo es am allerkompliziertesten ist, auch im gemeinsamen Bundesausschuss, wo man immens viele Vorkenntnisse braucht und da, wo es um Ziele und Wünsche und Inhalte und Use Cases geht, da fragt man die Patientenvertreter nicht. Ich hätte gerne nochmal, wenn Sie das jetzt vielleicht schon machen können, Herr Hofmeister, sehen Sie das auch so, dass man da vielleicht bei der Partizipation in dem Feld ansetzt, wo noch nicht die Spezifikation fertig ist? Wenn Sie da mit uns d'accord, also ich sehe es gerade wieder bei Tim, dass die Spezifikation, die dann auch die Versichertenseite betrifft, dann im April abgeschlossen sein und es hat vorher überhaupt gar keine Partizipation gegeben.
Because of course in the past
also
there
so
hasn't been
funktioniert
sufficient
sicher
participation, in
Beteiligung
my
nicht
opinion.
gut.
This is not the way we should go about matters. Thank you very much, Mr. Hofmeister. I'm sure you could try to respond. And perhaps you could also build the bridge to the European level to ensure that we don't only speak about Germany. Well, when it comes to Europe, I'm careful because with Mr. Van Hasselt, we have somebody who is a lot more knowledgeable. But generally speaking, I think we can agree that we have to ask ourselves who's going to be the beneficiary. Digitalization isn't good or bad per se, as many other things in the world. The question is always, what do we do with it? It has to be at the service of patients. That's imperative. And there's two sides here. Of course, we have the patient side, the decisive side. We doctors are also patients, let's not forget that. So I can, of course, speak about my personal experience, but then, of course, we also have the carers. Both sides need to be asked what makes sense. And we often experience in the course of digitalization that we intended to digitalize things that weren't apt for digitalization, and not from a technical level, but in terms of the process itself. And that is why I agree when you say that we need to discuss this. This isn't always going to be successful. I'm not sure who said it, but complicated matters can't always be deciphered in an easy fashion. That always is the difficulties, also in medicine and science. Some things are hard to decipher, to structure down, but the dialogue is important. And it seems like at the EU level too, when it comes to medicine, when it comes to healthcare, one intends to pay close attention as to what actually makes sense for citizens, what is necessary, what needs to be done first. And one further thing is very important to me. That question was implicitly asked with regards to the secondary usage of data. As a citizen and as a patient, I would always want to know that there is the theoretical possibility as to whether my data will be used for secondary purposes, and if yes, for whom. And if I don't like it, it would be a good reason for me to say, okay, I want to offer them, because of course data is the oil of the future, and therefore is a huge, powerful economic instrument. So especially when it comes to health data, it is important that we show absolute transparency vis-à-vis the citizens as to whether data is collected and offered also for secondary purposes. So I think this is a separation that always needs to be 100% clean. That leads us to a question of Sarah Roger. She is asking whether there are any ethical guidelines, whether there are ethical guidelines for the secondary usage of data. Mr. Van Haster, perhaps you could say something about this?
So indeed, when it comes to the secondary use of health data, there are great and legitimate ethical concerns when it comes to the reuse of health data. When you look at the way that the French and the Danish and the Finnish have introduced legislation and also these institutions to organize the reuse of health data, they have all done so in such a way that ethics and data protection are very much at the center of their approach. They have ethical review boards at the national level, which look at the request. They look at the request to understand what exactly is the purpose, what does the party requesting access to health data, what do they aim to achieve? And then on the basis also of the details of the request and the parties requesting the access to the health data, they will make their ethical judgment in line with their own ethical guidelines and legislation to determine whether such a request is or is not ethical. And what you see in many other member states is that they don't have necessarily a national ethics review board, but rather that you have decentralized local ethical review boards. So often in university clinical settings, you will have at the university level an ethical review board. There, of course, the challenge is that if you wanted to reuse health data from 50 university clinics in Germany, you would then have to wait for the approval of these 50 ethical review boards and the data protection boards and possibly also just management of these university clinics before you would even know whether or not you will be able to access the health data. And this, of course, is another barrier because if you are, for instance, a rare disease patient and there are only 100 patients with this rare disease across the EU, and then a number of these university clinics across the EU decided against approval of access to this data, that would impede the development of better diagnosis, the development of better treatment for these rare disease patients, which is, of course, not what we want. So this is why we're looking at how we can improve health outcomes for instance, rare disease patients. And we are hopeful that introducing these national infrastructures, national legislation, and protection at the national level, also for ethics and data protection, would promote the health outcomes for patients.
Dankeschön. Ich habe noch eine Frage.
Thank you very much. I see one further question from the chat. I'm not sure if I entirely understand it, says the speaker. I'll try to present it. The question is whether it would perhaps make sense to have a core data set to ensure that European countries can be compared. Now, I wonder, compared on what basis? Perhaps the person who asked that question could raise her or his hand so that there could be a verbal question. I can see that a hand is being raised. Ms. Weppler, please. I'm Weppler. I'm Mrs. Weppler. Can everyone hear me? Yes. I'm a colleague from the Social Ministry in Thüringen. I'm a colleague of Mr. Borde. Now, I'm speaking about data sets from criminals with mental issues. And the Constitutional Court also is sometimes interested in European comparisons. I realize this when it comes to psychologically ill patients. Well, experts were also summoned from other EU countries during the proceedings to see how long fixating takes place, under what conditions, etc. So against this background, it is important to find out how specifications are handled in other EU countries. And this core data set exists in 12 federal German states. So again, my question would be, to what extent this core data set could then be taken up by the Bio 42 system to ensure that at the end of the day, we can have a EU-wide comparison here. Thank you very much. My plan was to go back to Mr. Greve. Mr. Greve, perhaps you could try responding to this question, and perhaps after that you can also respond to my question, which would be, now what you've heard so far from the European Commission, has that given you more clarity as to what we can expect when it comes to data standardization? I would like to respond to both questions. First of all, when it comes to the core data set, I have no knowledge of this core data set. I would imagine that it's individualized for patients, so that for individual persons, data is provided. But if that is the case, then they will make sense in the electronic health record anyway. Otherwise, they wouldn't get in. In your case, perhaps there's documentation about 10 such prisoners, perpetrators. This will be data that should be available in the existing systems. But if these are patient individual data, then they can, by principle, be added to the record, but only if the patient wishes for this to be done. Whether that is the case in your example is something I do not know. That is something you would have to assess. But I do believe that the use case you have doesn't match perfectly with the voluntary health record infrastructure. But let's imagine they all wanted for this to be added. Then, of course, this data could be added to the records, and then it could also be standardized. And then the next step in this use case would be for this data to be analyzed, and that across Germany, across borders with other EU member states. For this, within the construct of the German health records, they would again have to be donated by the affected individuals. Regardless of the patient health record, it could make sense to standardize these data sets. But MIOS 42 would no longer be the right organization for this. But nevertheless, when it comes to this data, one can adhere to the same syntax and grammar rules, in this case, Hail 7 Fire and SNOMED, in order to ensure that the data becomes exchangeable and can be interpreted across the whole of the EU. But yeah, if I understood the question correctly, that is how I would respond to it. The second part is a lot easier. Mr. Benecke asked if I learned anything from this exchange, and my answer is a clear yes. I haven't had a deep dive into the EU level. Mr. Van Haastert said it. Gematik does this for us in Germany for years. I was also participating in the Gematik on behalf of the KBV, so I know about this, but I do not have that close a proximity to the EU topics, the national contact points. Tell me something, and the question in the chat was also whether Germany is also planning on setting up a national contact point. According to my knowledge, yes, that is a task of the Gematik, where this is also anchored, I think also legally anchored now. So these things are planned. What I learned is the correlation between the national contact points and the EHDS. It has made it a lot clearer for me, and therefore also the link to MyHealth@EU. These are things I now can understand better. I have a clearer picture of them. Now, Mr. Van Haastad also mentioned the guidelines of the EU. I already knew about this e-prescription, but it so far hasn't been relevant in terms of the MIOS depiction. But other things were mentioned too, raw data, for example, that is relevant for us. And this is something I would also like to take a closer look at. That would be it from me. Thank you very much. Our time is slowly but surely running out. Perhaps I'll ask whether there are any other interventions. I can see one. Mrs.
Genau, danke schön. Video habe ich, glaube ich, auch nicht. Ich wollte mich aber einmal aus dem Off melden und auch von Seiten der Ständigen Vertretung Referat Gesundheit danken für die sehr interessante Diskussion und auch Vorstellungen hier im Rahmen dieses Austausches und einmal dazu beitragen, dass sich tatsächlich ja auch hier wieder gezeigt hat, vor was für Herausforderungen insgesamt wir auch stehen, auch insbesondere der zu erwartende Vorschlag der Kommission für Herausforderungen vor sich hat, sei es, dass es vor allem um Technisches geht, um Daten schon mal für viele ein schwieriges Feld, weil es auch schon technisch ist, die unterschiedlichen Verhältnisse in den Mitgliedstaaten und wie bringt man das alles im Rahmen der Harmonisierung zusammen, auch die nationalen Kompetenzen in diesem Bereich ja sehr wichtig. Ich kann Ihnen nur für den Ausblick geben, weil das auch sehr viel jetzt der Schwerpunkt war auf der Komplexität und auf den schwierigen Herausforderungen aus Sicht der Bundesregierung im BMG, das ja federführend sein wird für diesen Rechtsetzungsvorschlag, ist ein sehr engagiertes Team in der Abteilung 5, die sich schon weit raus im Vorfeld sehr engagiert auch einbringen bei all diesen Fragestellungen und versuchen auch die deutsche Position sehr und die sehr vielfältigen Herausforderungen zu berücksichtigen und darzustellen. Und das Gleiche gilt hier auch für die ständige Vertretung, wenn dann dieser Vorschlag vorgelegt wird. Ich kann nur auffordern, uns auch gerne Ihre Stellungnahmen zukommen zu lassen. Wir sind jederzeit für Sie da, dass wir halt schauen, auch bei den Verhandlungen gemeinsam mit der Kommission und den anderen Mitgliedstaaten hier halt ein erfolgreiches Verfahren hinzukriegen. Und das gerade in diesem digitalen Bereich, wo wir in der Vergangenheit ja auch schon gesehen haben. Das eine ist, eine App auf dem Handy zu sagen und zu haben und zu sagen, das funktioniert ja alles super. Die ist dann aber meistens bereits für Milliarden von Menschen konzipiert, wenn man um Microsoft geht. Das andere ist dann für Detaillösungen, die passenden umsetzbaren Lösungen zu finden. Von daher wünsche ich uns allen viel Erfolg. Danke.
So yes, I wish all of us much success. Thank you. Well, Ms. Kassenbaum, this was a nice summary, and also thank you for your offer. Of course, in Brussels, all of us are going to have to work together closely here. I personally look forward to it, and I'm sure my colleagues do too. I would now like to give Wolfgang Borde the floor, say goodbye as a moderator, and I would like to thank all of you already for your participation in today's discussion. Thank you. Well, as the co-chair, well, together with Rainer, we've been heading the business for quite a while. All I can do is to also thank all of you. I'd also like to thank Sten for the great preparation of this event. I think we've been given good insights into the problem. Some of it was known, some of it perhaps not. I would also like to ask Mr. Van Hastert, once your proposal is available, perhaps you could honor us once again in the working group to have a discussion. I'd like to thank all of the participants, Mr. Greve, Dr. Hofmeister, and Mr. Van Hastert. Thank you very much for this very interesting information you have offered us, and what Ms. Kosterbaum nicely said too, I'm sure. We'll meet again to discuss this topic. And just like Sten, I look forward to further discussions. And this would be it for now. Thank you very much and goodbye. Wolfgang, could I briefly say something? I'd like to thank our IT colleagues that also made it possible. During the pandemic, it's extremely important that IT has been able to help us and that we are able to communicate online. And I'd also like to thank the interpreters for the translation. The interpreters would like to thank you for listening. We had about 100 participants on average, which is a huge number. And just like you, Wolfgang, I agree. It is important that our event has a certain degree of sustainability. And that is why I would be grateful for any further information in order to ensure that we can follow the topic and that we can also have the discussion with the DG Santé within the working group. That would be important to ensure that this isn't only an event that will disappear in thin air. This topic is too important. Even in these difficult times, the topic is too important to only handle it once. And this is why I would like to thank all of the people that have helped us thus far again. So that would be it for now. Goodbye. And let's hope that the world still exists in a few days. Bye-bye.
Bye.